Increased intracranial pressure is found on page 1110 and 1111 in your textbook. 1110 and 1111. I'm gonna eat that protein bar. I got gunk in my throat. All right. Intracranial pressure or increased intracranial pressure. Intracranial pressure is the pressure of the cerebrospinal fluid in the subarachnoid space. It's that little cushion of fluid between your skull and your brain, and we measure that, and it's called intracranial pressure. We measure how, just like blood pressure, same type of thing. When your blood pressure gets high, it's pumping too hard. There's maybe a lot of fluid. Your heart may be working overtime, different regions. Your vasosystem could be constricted, which is causing an increase in pressure because of the amount of blood that's going through it. Same type of thing can happen with intracranial pressure. It's the amount of fluid. So the fluid can increase, the fluid can decrease. You have a leak. You can have it where the ventricles within the brain, so inside the brain, there are these ventricles, that's what they're called, not to be confused with the ventricles of the heart, it's ventricles in the brain, and they process that cerebral spinal fluid, they help it to excrete, and sometimes they stop working and you have an issue, sometimes there's an overproduction and you have an issue, and sometimes there's swelling in the brain, and so when the brain swells and you have fluid in there, that fluid gets tighter, right? More pressure because the brain is taking up more space. If you think of the brain as a locked box, as a suitcase, there's only so much space in there, right? Once that gets full, be it full of tissue, fluid, whatever, the brain is swelling and increasing in size, there's only so much space. So with that, you get more pressure with the fluid that's there. Increases that pressure, pushes against the brain. It pushes against the spinal column because it goes down your back and you have cerebrospinal fluid as well in your spinal column, right? That's why we do lumbar punctures. And so when we have increased intracranial pressure, if we do a lumbar puncture, what can happen? That fluid can really push out and you can develop a leak in that hole. A lot of times if we have increased intracranial pressure, unless we feel that the benefits outweigh the risk, we typically do not do lumbar punctures with increased intracranial pressure because a leak will develop. Okay? Because there's so much pressure, it'll start leaking out. And then if you don't have the fluid that you need, your brain has no cushion. If your brain has no cushion, you get a really bad headache, and it can cause more damage to the brain to not have that cushion and protective cushion there. We don't want to do that. So, like I said, it can be a result of an internal or external factor that's causing issues. It can be your fluid overloaded. Well, could be a number of things. It can be internal or external. Normal intracranial pressure is 0 to 10. If we have 20 of mercury, millimeters of mercury. Millimeters of mercury. With small increases of blood volume leads to elevations in increased intracranial pressure. So if we have more fluid and then we increase our blood pressure or blood volume, we can have increased intracranial pressure, okay? If the pressure gets too high, if the swelling gets too much, if the pressure gets too high, then ischemia or lack of blood flow to the brain can happen. Because when you get all that pressure putting on the brain, then those little capillaries within the brain can't perfuse because there's too much pressure, which causes ischemia. So we have issues. It can also, depending on where it is, you can also reach a point to where there can be, it can cause herniation of the brain, depending on the location of the issue. almost pushed the button on my laptop. I wouldn't change it. This is a neat little pygmonic for increased intracranial pressure. I really like this pygmonic. It's one that I think gives you a good indication of what changes in LOC and changes in your client's going to look like. Whether they're adult or a child, increased intracranial pressure pretty much looks the same. Maybe an issue with changes in speech because of the ages. But with infants, we'll have the bulging fontanelles. The cranial sutures will separate, you'll see that. Their head circumference will enlarge, and they have that shrill, high-pitched cry. So we can see all of those other things as well. I would make a note of Cushing's triad, because when you see that, which is an increase in systolic blood pressure, a decrease in pulse, and their respiration pattern changes. If you look at chain Stokes, or it can be very slow and deep, you'll see some changes in their respiratory pattern. Sometimes with that systolic blood pressure, you may see a widening pulse pressure, but when you see that, that means it's getting worse. And we have to be careful of that. So if we see those vital signs changing, or recognize that it's an elevated systolic blood pressure, a decreased pulse, and an altered respiratory system, usually it's a little bit slower, then we know we have an issue with increased intracranial pressure that is progressing. Okay? Again, recognize that the head circumference can enlarge until the age of 5. But we will see the changes in their eyes. We'll see the changes in the LOC. If they're old enough to hold their head or indicate pain in the head, you will see a headache or indications of that. Sometimes kids will, even when they're little, when they don't know, they'll kind of bang their head. So sometimes you can see that in an effort to stop, stop hurting. So they may bang their head or hit their head. If the head hurts, then they hold their head. Your little kids will do all those things. Their hands will be on their head. You'll see those changes that way. They'll show signs of a headache. Seizures will come with increased intracranial pressure because it will cause a misfiring in the brain. They may have the posturing and then decreased motor function. They're just not going to be able to follow commands and changes in their LOC. So assessment is going to vary according to the age of the child and how quickly this increase happens. So let's say they have a tumor, a brain tumor that's growing slowly. They're going to ultimately have an increased intracranial pressure because the size of the tumor is growing. But because it's happening slowly, you may not see the changes in the child as quickly or as, it may not be as obvious because it happens over time and the body learns to adjust, right? Our bodies are so miraculous. But you will eventually start to see changes as that progresses to get worse. But if it's a slow process, then it may be slower to see those changes, right? If it's a rapid process, somebody's been hit in the head with a baseball bat and they have a fractured skull, you're going to see changes in LOC pretty quickly, right? So early signs are going to be changes in LOC, lethargy. A lot of times you'll have nausea and vomiting. Your kids with shunts, if that shunt gets backed up and they start to have issues with increased intracranial pressure, they'll vomit. One of the first symptoms, they'll get irritable and they'll vomit. They get a headache. Seizures. Then late signs, we're going to see that decrease in LOC go more towards your unconscious and coma states. We'll see some swelling around the eyes, the papilledema, and then Cushing's triad, right? When we see Cushing's triad, we know it's getting pretty rough. And be familiar with your Glasgow coma scale. So, some of the different things that we're going to look at for labs and diagnostics might have these issues are gonna be your CNC, your CMP, your X-ray, your CT, your MRI, and your EEG, okay? And we talked about that earlier. Interventions. Again, monitor, 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 assess, assess, assess. Always, always, every little bit, you want to be checking to see if there's changes, especially if this is something that happened all of a sudden, okay? We need to be very, very meticulous about our assessments and look for changes. Monitor their neurostatus, monitor their airway, their vital signs. Look at IV fluids. Now, we have to be careful with IV fluids because if it's a fluid overload issue, if we have a child with a blocked shunt, we're not necessarily going to want to put a bunch of IV fluids in them. That's going to increase that, right? So we have to be careful with IV fluids, but we also need to maintain hydration. So we're going to be watching that. INO, their daily weights. We're going to use that Glasgow Coma Scale. Why do I struggle with that word so much? I don't know. And then also our labs. We're going to be looking for any changes in their CDC, CMP, anything that could indicate issues with infection, and anything like that as well. We're going to administer medications to decrease that cerebral edema, which most of the time is mannitol. We may also give anti-seizure medications. And if it's a blunt force trauma or something like that, we may have to give them pain medication. We're going to administer medications while assessing and monitoring and recognizing. So you need to know your side effects, right? Because if there's a side effect of a headache, is the headache coming from the increased intracranial pressure, or is the headache coming from the medication? Right? So what other assessment values can we look at that might give you an indication of that? Changes in LOC. If we have progressive changes in LOC and a headache, there's a good chance that's coming from the increase in your cranial pressure, right? Because your LOC changes are still deteriorating. But if those LOC changes are getting better and we have a headache, then there's a good chance that's coming from the medication, right? So think about those things. We want to make sure that we're providing support and encouragement to the parents and the child. Always communicating with the child what you're doing, even if they're in a comatose state. You need to tell them what you're doing. I'm going to change your diaper now. I'm going to clean you up. I'm going to give you a bath. I'm going to move your arm now so that we can exercise your arm. Let's move your arm. Talk to your patient. But the other thing is appropriate stimuli. Sometimes with increased intracranial pressure, these kids are irritable and we need to reduce stimulation. We have seizures, we need to reduce stimulation, but we still need to make sure and take care of the needs that they have. So that's a balancing act as well. We may want to cluster care. These kids are kids. So we don't want to take away their family interactions, but we do want to encourage family members to stay quiet. They can talk to them, but don't do things that would cause irritation to the child. Does that make sense? We want the family members in there because that's going to bring them comfort. And then we may need a craniotomy where we drill a hole to reduce that intracranial pressure. And that comes with neurosurgery. So think about surgery, bleeding, infection, all those lovely things with surgery, dressing changes. And with surgery, there's a risk for inflammation. But sometimes, again, the benefits outweigh the risk. Does that make sense? So,
last time we were talking about they might not need IV fluids because that might it works. Things like that.
Okay, so if I'm understanding you correctly, and you're trying to cut down on it, so I hope I can answer. You might want to type it into your chat if you can, if I don't answer it. But the thing of it is, what is your cause for your increased intracranial pressure? Okay? What is causing it? If you have a cause that they're fluid overloaded and their body is producing too much spinal fluid, or they have too much cerebral spinal fluid, then we need to be careful in giving them IV fluid, right? Because if we give them more IV fluids, it's going to produce more cerebral spinal fluid, could add to their volume overload, and increase their increased intracranial pressure that much more. So it's a balancing act that way. If the cause of increased intracranial pressure is due to blunt force trauma, or something like that, then it's swelling in the brain, and we still want to be careful, but really we're going to be giving mannitol, or we're going to be giving steroids and things to reduce the swelling, but we have to maintain hydration as well, and if they're unconscious, they're going to need IV fluids. So it's that balancing act of giving them enough to maintain hydration without overloading the problem. Does that make sense? Does that answer your question, Aubrey? Okay, good. So, education and teaching for this is what's the cause and why do they have it? Can we prevent it? Can we do something that education-wise helps them to not have this happen again? Anticipatory guidance, what can we do about it in the future? What can we teach them to do to help when this happens, or should it happen again, like your kids with shunts? We do have to teach those parents what the symptoms are when you come to the ER. If they're vomiting and have a headache, you need to make sure that they're bringing them to the ER to check that shunt out. So anticipatory guidance, what can we teach them? Kids on bicycles, or helmets, kids on roller skates or skateboards or helmets, right? Motorcycles or helmets. So those are things that we can teach prevention for. We can teach those things. This is safe. This is how you prevent this from happening. And then resources if this is an ongoing problem, you know, or if they're going to continue to have issues, or when they go home they need additional care to get them through so the child is completely well. Resources, home health, those types of things. Additional physical therapy, occupational therapy, whatever, to help these children to do what they need for these resources. Okay. Traumatic brain injury starts on page 1123. So traumatic brain injuries, I've kind of talked about this already when I'm talking about increased intracranial pressure, that it's a jolt or blow to the head that disrupts normal brain function. It can be classified several different ways. If it's penetrating, think about like a bullet, it goes into the skull, it penetrates. Blunt, and typically it's not going to go into the brain, but they fell from a tree and they hit their head. Primary injury can be directly from trauma. Secondary injury can be a result of complications. Okay, so one of these that you think about is a car accident. You hit the brakes, you hit your head, you bounce back. Your brain does the same thing inside your skull. It goes forward and then it goes back. You can have contusions on both sides of the brain of a child that's been in a car accident, or an adult for that matter. But it's a complication of the injury, because the first injury is the first one and then it bounces back, and that's a secondary injury. It can also be complications. So let's say that they had something that caused an injury, a penetrating injury, and then they get infection, and infection is a secondary injury because it caused increased intracranial pressure because of the infection, and so therefore we have additional anoxic and issues that way because of the increased intracranial pressure and the added infection. Okay, that's a secondary injury as well. Direct brain injury is where the brain itself has been penetrated versus a skull. The brain itself has been injured. Indirect brain injury is structural deformation occurs. So that can be something along the lines of the structure within the brain. It's also due to an accident or injury or bullet or whatever the case may be, but there is structural deformation. That can also happen with your neurotube defects. Okay? Structural deformation. Something within the structure of the brain stem, the way it's held within the skull, any of that can cause some issues there with your indirect brain injury. So some of our obvious signs are going to be blood on the scalp, depression of the skull, any type, if it's a penetrating wound particularly. You can also have changes in LOC and loss of consciousness, altered LOC, you could have seizures. Again, you could have the combativeness that can happen and vomiting. So if you think about concussions, they make you, that's a traumatic brain injury from being hit on the head or falling or whatever happens that causes that concussion, being hit hard, whatever. And they have increased intracranial pressure and issues, they're going to vomit more than 3 times. Once they vomit more than 3 times, we know there's a big issue and we need to be following up. Assess that neuro status. Again, CT, MRI, EEG. You may have to monitor the increased intracranial pressure, cerebral blood flow and perfusion pressure. And some of that is done through central lines. And then that are in the carotid, right? And again, like I said, you don't want a lumbar puncture because that can really have an issue with increased intracranial pressure. But if intracranial pressure is monitored through changes in symptoms, so the main thing you want to do is make sure that we're preventing life-threatening complications, maintaining a patent airway, getting oxygen, constantly assessing that neuro status, looking for issues with their head and neck. Hemotympanium is blood behind the ears or blooding from the ears. Battle sign is the bruising behind the ears, and the raccoonitis is bruising around the eyes, and there's a picture that comes next. We want to make sure that we have large bore IVs. You preferably, you may have to really push medications to maintain their life, to reduce the swelling and to attempt to control their blood pressure and then attempt to keep them breathing. You may want to give an isotonic fluid and keep it warm. We don't want any shock going into the body or anything that can affect or overstimulate the body or the brain. Again, we're going to be assessing and reassessing and looking at their intracranial pressures and document. So I have a question here about basic things with a concussion. What are the signs to watch for? Can they go to sleep? If they vomit, do you take them to the hospital? And what point do you become concerned that it's something more? Okay, so we've said for a long time, or you've probably heard old wives tell that if somebody hits their head, don't let them go to sleep. The issue, or what you really, they can go to sleep, but the thing is you need to wake them up frequently to assess their neurological status. The problem is if they go to sleep and you go to sleep and you don't go in and check them again, and they have a change in LOC and then you can't wake them up, then it's a bigger problem. So with that, they can go to sleep, but you need to go in every hour or 2 hours and assess to make sure that they're okay. The vomiting is more than 3 times, but a lot of times there may be initial swelling, but it'll go down. And so they may vomit initially, but that could also just be from the trauma of their brain and the pain. So we're looking for that vomiting more than 3 times to take them to the hospital to have any concerns with that. Changes in LRC is when you need to go to the hospital. When they're not acting right, if it's a baby and they're irritable and crying and sick, vomiting and all of those things, we need to take them to the hospital. Okay, irritability is one of your big changes in LOC for your infant. And the vomiting. Okay, does that answer your question, Jennifer?
Yeah.
Yes, I see you now. Yeah, okay, good. So documentation, again, the story is, if you don't document it, you didn't do it. So we need to document everything that we're assessing. What do we see? When we monitor our intracranial pressure, what are we looking for and what do we see, and we're documenting that. Because your next shift comes on after you and you may give reports, but they also have to look at that assessment to know if there's changes. So there's your battle sign and your recognize. So again, we want to prevent any traumatic brain injuries. Don't leave loaded guns at home for kids who can get to them. If you are going to have guns in your home, make sure you educate your children maybe appropriately. Anything else that we can do to prevent, like I said, your helmets, all of that stuff. Okay. Home care, short-term or long-term, whatever they need according to what happened with them, support and resources, same as the other. Okay, so abusive head trauma, shaken baby syndrome, infant or child shaken to the point that it causes neurological damage. It may be intentional or unintentional, and typically it's 6 months or younger. We have some changes in their LOC. Their neuro status, they're just not what they usually are. So the neuro status is off. Just their assessment. It's your baby, it's your child, and they're not acting right. They're not being themselves. They may have seizures. They may have some issues with their breathing. Bulging fontanelles, they may be in a coma, non-responsive. There may be bleeding or hemorrhage, which can cause a stroke in the brain, right? That's what hemorrhage in the brain is, a stroke. They may have some bradycardia and cardiovascular collapse due to what controls our heart? Our brain, right? So if you have damage to your brain or your brain stem, it can cause cardiovascular collapse, cause some issues. And that's, you're going to see that in the moderate to severe. When it's less severe, it's going to be more like a concussion type of symptom, so you're going to see the vomiting. You have some issues with thermoregulation. This is hypothermia. They're not going to feed well, failure to thrive, they're going to be sleepy or lethargic, irritable, difficult to arouse. So when they do wake up, they're kind of cranky babies, and just not, they have that high-pitched cry to them. It's just not going to be normal. And sucking, if you think about sucking, it causes pressure, right? It causes pressure in your mouth and in your sinus cavity. And if you have increase in your cranial pressure in your brain and you suck, what's that going to cause? It's uncomfortable, right? It's going to cause more pain, more irritation. So these babies aren't going to want to feed because it hurts. Routine labs, you want to do the UA and look for your drug screen, CT, MRI, and An ocular endoscope will show tearing, so this is, they look deep into the eyes and it'll show the blood vessels within the eyes have been torn, so they'll see issues there. So again, we want to do respiratory care, cardiovascular care, support, monitor for increase in intracranial pressure. Now we have to be careful with an NG tube, because if we have increased intracranial pressure and we put something down their nose, it can increase that pressure as well. For fractures at the back of the skull, subarachnoid fractures, we don't put NG tubes down. So we have to be careful, but we do want to make sure that we are addressing any nutritional deficits. And so again, that's going to be a doctor's call. But you do have to be careful. And know that with some fractures, we don't put down NG tubes because it increases that pressure. We will watch their I&O. We want to address and document any visible injuries. And when it comes to legal and ethical responsibility, your textbook really does a pretty good job at addressing some of this. Let me see if I can find that page number. I will find that for you and do it for you on Thursday or put a note out for you. I will tell you on head injury, if you look at page 1128 in your textbook, there is box 30.5, which is the clinical manifestations of acute head injury, so you'll see those changes. And then emergency treatment is also a box there. It kind of tells you what to look for and what to do as an emergency treatment for a child that's had a brain injury. I have all those page numbers written down, but I'm looking at my slides and not going through my folder, so I apologize for missing those earlier. But it is, if we suspect abuse as a nurse, it is our responsibility to report that. Okay? But you also want to make sure that that's really what happened. So look at history. Look at the child's history. See how the parents are responding to the child and all of those things. I will find those page numbers in your textbook. I'll get those to you. Prevention. Parental concerns, you want to talk about it. You need to look at whether this child's going to have short-term or long-term care issues and whether they need to be can be taken care of at home versus need to be in a facility, and address those questions open and honestly and help them to assess their ability to do that. If this is a shaken baby syndrome and we have an issue with abuse, we are going to collaborate with police and DHS. Documentation must be flawless. So guys, if you're going to be called to the stand, you need to make sure that you're very thorough in your documentation on this. Drowning or submersion injuries, you don't always think about those as changes in LOC or your neurological, right? But what are they? They are hypoxic injuries to the brain. So drowning and submersion injuries are preventable. And you will see a lot of times symptoms in these children or issues if they've gone a time without oxygen and they actually died and then are revived or brought back with CPR. Sometimes they can have a wet drowning and sometimes they can have a dry drowning. So sometimes they're in water when they drown, and sometimes it can be an aspiration issue. It can be they fill up with fluid, they can have a laryngospasm. Issues like that without aspirating. So sometimes they just have an injury that causes them to have that lack of blood flow to the brain. It can be any mode of water. Remember, it doesn't take but 6 inches to drown. So, really want to look at how severe the hypoxemia is, and that really helps us to know what their chances of death are and what their long-term effects are going to be, how bad the hypoxemia is. So it really depends on how long they were submerged and the temperature of the water. Cold water slows down body functions. And people that are submerged in cold water are more likely to come back and be fine than those that are submerged in warm bodies of water or warm water. Warm water vasodilates. More likely to have some issues with that, right? When you think about vasodilation and all of those things, and then you bring in the swallowing and the submersion and all of that, it causes issues, whereas cold water constricts, reduces the brain size because it's constricting, and so they're easier to recover. You do have to look at confusion or coma, hypothermia, changes in their heart rhythm with dysrhythmias, tachypnea, tachycardia, hypoxia, seizures. You want to make sure we're assessing their neuro status. We have a continuous pulse ox to look for respiratory distress. We're going to look at hypovolemia or hypothermia. We're going to look for those ventricular dysrhythmias that can kill. And then there's the Orlowski scale, which is a scale that is used that helps to determine the severity of injury with submersions. That's all you really need to know. I'm not going to tell you need to know that in and out or what is, other than that's what it's used for. Okay? ABGs, arterial blood gases, are big to know exactly where we're at with their breathing and whether they have had a lack of blood flow and an increase in their CO2. CBC, CMP, coagulation studies, liver enzymes, chest x-ray, all of those things need to be looked at. And sometimes it can be a dive injury where they, dove into a pond or whatever and broke their neck and were underwater, so we checked their cervical spine. We're going to do the echocardiogram to check their heart out. And then ECG as well. And maintain their airway. We want to give them oxygen, utilizing an arm rebreather. Provide life support measures as necessary. CPR, ventilator. All of those things. We're going to suction all their secretions. Be conscious of vomiting. We may put down an NG tube to remove stomach contents and to help prevent vomiting. We may also need to feed them later through that, depending on what their changes in LOC are, whether it's for just a time or long term. I'm going to do the IV fluids, and we may have to use Lasix or other types of just depends on how severe and what we're looking at. We also may give the IV fluids if they're hypovolemic. Okay? I'm always looking for other injuries. Again, prevention. Gates, removing ladders to get into pools, fences, gates, alarms, life jackets on all boats, or in the water at all if they're at a lake. Even if they're just playing on the beach, you want to put them in a life jacket. Use prevention. Again, home care as needed depending on the severity of their damage, support, and resources. Seizure disorder. Are caused by an electrical disturbance in the brain. It causes a change in motor function, sensation, and or cognitive ability. Sometimes, in some seizures, they just basically just zone out. They're not there. You can't get their attention, and they're just out. They don't move. They don't jerk. They don't do a full, it's not a full body seizure, it's a partial seizure. But they're cognitively not there, okay? There are a variety of causes. With epilepsy, the seizure will last seconds to minutes. Status epilepticus is a emergent situation where the seizure lasts longer than 20 minutes. Or it can be a continuous set or series of small seizures in which that 20 minutes they never come back to full consciousness. Guys, my battery on my tablet is running low, so I don't have my plug with me. I don't think so. So I may lose you on my tablet Zoom link. But you're still going to be able to see, and you're still recording, so we should be okay. You just won't be able to see my face. Sorry. Okay, so for those of you, again, that are knowing others and need to experience these, you need to go on YouTube and you need to search for different types of seizures. There are links here for different types of seizures that are there. They are good links. I looked at them again yesterday. They should still be valid, so you can pop those in and be able to watch some videos that kind of show you what a partial seizure is versus a generalized seizure. The big thing with seizures is we're maintaining their airway. We're timing them. We're making sure that they're safe. So if they're in a classroom and we know they have seizures and a seizure starts, we want to make sure that we lower them to the ground. We turn them on their side so they can't aspirate or have issues. We want to make sure that nothing is around them that they can hurt themselves on. That's providing for safety. Again, we're timing it, we're documenting what it looks like. We're maintaining that airway. There are a lot of labs and diagnostics because of the different potential causes of seizures. And I should tell you that in your textbook, seizure disorders start on page 1141 and go through page 1157. 1141 to 1157. And there's a lot of information in there. For those of you that are linguistic, be careful. There's a lot of information in there. Make sure that you stick with what's important to know. Okay, what's in your guide, what you need to know to help maintain their safety, those types of things. Okay, there are a lot of treatments that are out there for seizure as well, and some of those are documented in your book, and different types of diets, things like that. So don't get too heavy into that. Just know that those are potential resources, okay? All right, so CT scan, MRI, angiography, EEGs, lab, lumbar punctures, skull radiograph, x-ray of the skull, angiography, that's going to be like your heart test, but it's going to check the carotids out. There's an EEG. And sometimes in seizure wards, you'll actually see kids that have these on all the time. Seizures, you will do a lumbar puncture because if you have an infection that's causing a seizure, then yeah, you'll have to do that. It's fine, but that's the reason. The question here is, how do you maintain an airway when they're having an active seizure? Well, yes, turn them on their side, right? You're not going to stick your hand or anything else in their mouth, okay? You do want to, if you have the opportunity, you may provide supplemental oxygen. But the main thing is turning them on their side so they can't aspirate is probably your biggest issue. If they seem to be clamping down or, where they're cutting off their own airway, you may help to do a chin lift. If you can, depends on is their head moving. If their head isn't moving during the seizure, then you might be able to do a jaw thrust, chin lift jaw thrust to help keep that open on them. But I've seen seizures where heads going all over the place. So, it just depends on the type of seizure. You couldn't do that with someone that their head is involved. If it's not, then that's an option is to do, if you see that they're gasping or that their tongue is falling back, turn them on their side and then work on doing that jaw thrust, okay? You don't hold anything with seizures. The main thing is if their head is moving, you might provide a pillow or put your hand below between their head and the floor to provide a cushion. It may hurt your hand, but if they're in a bed, but if they're on the floor or a concrete, I had a lady go down and have a seizure on a sidewalk one time, and I put my hand between her head and the concrete. My hand was all scratched up, but her head was not. And I was okay with that. So, that really does happen. So, those are things that you want to make sure you're watching. So again, airway management. Provide medications if you're in a place where you can, and you want to give them the medications to stop the seizures or to assist with the seizures. Seizure precautions. Seizure precautions, if they're in a unit where we're monitoring for seizures, a lot of times these seizure precautions are already taken. The bedrolls are going to be padded or softer. They're going to have a suction catheter kit already in the room, because you may have to suction their secretions. That's another airway management if you're able to, but you may not be able to. You may have to wait till the seizure stops and they're in that post-ictal state where they're not really coming to, they're real drowsy. At that point, you may have to do some suctioning to keep them from aspirating. But usually you have that suction catheter kit already in the room. You already have their bedrolls padded. Or softer bedrolls, or the beds are made for kids that are having seizures and they're in that unit, and that's what they're being tested for, and they start to have a seizure, then assume that that's already taken care of, okay? Provide continuous cardiac, respiratory, and oxygen monitoring, and check their blood sugar, because blood sugar can also be a cause for seizure. And it can also cause issues with blood sugar. Because if you think about it, if you seize, there's a lot of energy that's expended, which can use up your blood sugar. And so they can have low blood sugar after. So we want to make sure that we're monitoring and checking their blood sugar. Document. Be thorough. What are the events leading up to the seizure? What did the child feel? What did the child say? What did they do? How did they act right before the seizure hit? What's going on while the seizure is going on? All of those things. Duration of the seizure from the time it started to the time it stopped. And then also their post-ictal state. How long did that last? How long were they drowsy? How long did they have trouble waking up and responding? What was the muscle tone? Did they have a full absent seizure where they lost all muscle tone and fell out of the chair because they can't maintain or just fall to the ground or whatever? What did their muscle tone do? Did they have flexion where everything's pulled in tight? Did they have movement? What was their muscle tone and behavior? Changes in their facial expression, particularly their eyes and their mouth. Are they gritting their teeth and grinding their teeth? Are they having issues with their tongue and gasping and, that kind of thing? What's going on with their mouth and their eyes? Are their eyes open and just not moving, not paying attention? You could clap your hands right in front of their face. You could go point at their eye and they're not gonna blink, but their eyes are open. Are their eyes closed? Are their eyes fluttering? What's going on? Because that also is a good indicator. Do they go fixed? Do they go pinpoint? Do they go dilated? What do they do? Color is skin tone. Do they turn blue? Do they turn bright red? Color, that's what that means. Skin tone. We're documenting all of this. Do they sweat? Again, pre-seizure activities. Were they watching a TV show and a commercial came on with flashing lights that caused them to have a seizure? Was there loud noise? Was there excitement or stress or fever? All the seizures going on, did they cry? Did they make noise? Did they moan? Did they say anything? Sometimes they'll even have random activities while they're doing a seizure, so they can be in a seizure and wander. They're walking, but they're not, nobody's home. They're completely out of it. So are they wandering? And some of those videos, you'll see kids that have some of those seizures, partial seizures, where they just lose consciousness, but they're still sitting there. And they may be writing when it happens, and then their hand will just move off to the side. It's like a wandering movement of their extremities. The position of the eyes, the head, the body, extremities, again, all during that. Where were they when it started? What was their hand doing, their mouth, their eyes? What did it look like when it started? Did they have incontinence? How long did the post-ictal state happen or last? What was their state of consciousness? Were they arousable? Did they know what was going on? And what were they able to do during that post-ictal state? A lot of times, you see a change in motor function, so they're extremely weak. They may not be able to move all their extremities. They'll have some weakness. Their speech may be a little more slurred than normal. And they really don't have a lot of ability to sense things. They'll touch, somebody touching them, things like that. They may have discomfort or pain. And you need to ask them what happened before you had the seizure. Some people have auras, so they know when the seizure is going to happen because they have a sensation, an aura. Kids can have those as well. My mom has seizures, and she has tingling in her hands when she's going to have a seizure. So when I'm looking at my mama and she starts rubbing her hands, and she kind of gets this far off gaze, I'll say, Mama, do you need to lay down? Mama, do you need to lay down? And usually she'll say yes. And so then we know the seizur's coming. Kids can do the same thing. They have an aura, they have a smell, they have something. If they know a seizure is coming, sometimes it's a smell. They'll smell something. And it'll be like, okay, I'm gonna have a seizure. So they teach them to lay down when it comes to auras, but ask, what did you feel right before the seizure? Once they start to come to, ask those questions so that you can see if they have an aura. My mom, it's that tingling in her fingers, and she'll start rubbing her fingers. I'll be like, Mom, you need to take medicine? Mom, you need to lay down? And just know. Just know. And parents can do the same thing with kids that have seizures. They'll start to recognize those auras, those characteristics. We are just about ready to shut off. We will get into more about, not quite where I wanted to end, but I'm close. I'm good with where I'm at. I'm hoping to get through headaches.